This is case of the day, and today is the 124th case. I've lost track of which week or month we are in. But it's a very simple enumeration of the direct and indirect signs of lumbar spondylolysis. So, this is a 37-year-old with back pain, has grade 1 spondylolisthesis of L5 over S1. So, clearly, we should look at the pars, and you can see a defect on both sides, elongated pars with a break, and this must have been an injury in the past, and that has also led to this unusual shape of the pars, which often happens with these long-standing defects. I did do case 55. This was, I think, just before some holiday, and we looked at grade 4 spondylolisthesis because of spondylolysis and some of these signs. But while seeing the defect directly is the best way to make the diagnosis, often we see that the diagnosis is missed in many patients. And so maybe sometimes if we have a high index of suspicion for some of the indirect signs, then maybe we would make an extra effort to look for lysis. And one of them really is just spondylolisthesis. When we see spondylolisthesis in younger people, I think the first thing that should crop up in our head is there spondylolysis? And then you look at the parasagittal images and try and look for a defect and make the diagnosis. The second is this increased spinal canal dimension. They say it should be more than 1.25 times that at L1, but you can see here clearly that there is a significant increase in the size of the spinal canal dimension. And this is another patient with grade 2 spondylolisthesis because of lysis, and you can see the significant posterior displacement. So what really happens is, because there is a defect, the posterior elements are now unmoored, right? And they can move posteriorly. So if you were to actually draw a line along the spinous processes, you will see that while this line remains almost straight and curves just a little bit, suddenly there'll be a change in the curvature because the spinous process has moved backwards, and that leads to this increased spinal canal dimension. And the moment you see it, it's actually quite visual. It invariably means that there is lysis. Then we have the posterior wedging or the reduced posterior vertebral height, and it's seen in the second patient as well. And I don't quite have an explanation. I guess it's related to the mechanics because of the movement between the anterior and the posterior elements. But this is usually seen, and while at the other levels the anterior and posterior lines are almost the same or a little bit of difference, you'll find a significant difference here. And again, there are values, and it's anything less than 75% is significant, but nobody really measures. You just look at it, you know that there's reduced height, and that should again suggest that there is lysis. The last one is not always seen, but when seen, it's a very interesting sign, and that is the epidural interposition fat sign. So normally, when you look at the epidural fat, it gets interrupted. It's not a normal. It's not a continuous line, but at the level of the spinous process, the dura is attached to the spinous process, and the epidural fat posteriorly gets interrupted. Whereas because of, again, the posterior movement of the spinous process and the posterior elements because of the lysis, eventually that tethering is gone and you find a continuous column of posterior epidural fat. But it's not always seen. So the index patient that I'm showing does not have the epidural fat interposition, though all the other signs are present. So when you see it, it means there's lysis. When you don't, it doesn't rule it out. So these four signs, very helpful. Spondylolisthesis in a younger patient should trigger a search for a defect. In fact, in any patient, that's how I've been doing it for the last 20 odd years. Increased canal dimensions, reduced posterior vertebral height, posterior wedging, and epidural fat interposition. This article is helpful. It lists the various signs well. And of course, these days we have slowly started incorporating CT-like bone image, or zero echo time sequences, which behave like CT and give added confidence to our diagnosis. And we'll be hearing more of this as we go along, because we're slowly adding the sequence, trying to do it without increasing the scan time. But more and more, it's becoming part of our routine protocol. So, in summary, we should be alert for indirect signs that point towards likely spondylolysis, so we don't miss the diagnosis. My WhatsApp channel, and thank you so much for viewing this.